Okay, thank you everyone for coming. We're going to get started now, but feel free to eat, enjoy. I am Kimberly Morse, a social worker from Children's Hospital Los Angeles, along with my co-chair, Brandy Midder-Oxley from Children's Atlanta, and we are excited today for Smooth Operators, Creating Innovative Transitions to Adult Care. And I don't know about any of you, but Smooth Operators, is anyone that remind you of the Sade song from the 80s? Yeah. We should have had it playing in the background, but we didn't. So we're excited to hear from various disciplines, from centers across the U.S., across the pediatric to adult care continuum. Nanette's going to open us up about her CF Care Center, how they started a new transition program and protocol. And then we're going to learn about education, resources, and data from Diana, Christy, and Megan's programs. And then we're going to wrap up with lessons learned from a well-developed 10-plus years program at Randi Center. So without further ado, I will introduce Nanette Concotelli-Fisk, LCSW. Nanette Concotelli-Fisk, LCSW, practices clinical social work at the University of New Mexico in the pediatric pulmonary CF clinics. She provides direct support to children and their families living with chronic and severe respiratory distress. Since 2008, Nanette has collaborated with the CF team members to develop the CF Pediatric to Adult Care Transition Protocol. She also chairs the UNM CF Transition Subcommittee, which we'll hear about, whose primary work is to refine the transition protocol. Nanette is a past president of the NM chapter of the National Association of Social Workers. Impressive. And she's social work faculty with the New Mexico Leadership Education in Neural and Related Disabilities. Ooh. In her spare time, Nanette enjoys working in a family-centered practice, collaborating with an interdisciplinary team. Wow. Welcome, Nanette.
This is really fun. Thank you so much. I'm part of a larger team. I'm not the only person that works on this transition protocol, and I'm going to call them out. Go ahead and stand. I told them I was going to do this. So the UNMCF team, they're up there at the front corner, too shy to stand. So thank you. And it's Saturday and we made it through. And I saw Kim Reno and she still had the biggest smile on her face. And I'm like, that's impressive. We're all still smiling. It's Saturday. We're here. So thank you. And thank you to the panel co-chairs. All right, so I'm Nanette. I like to say Nanette from New Mexico. It's really easy to remember it that way. So we're here to talk about developing a transition protocol. So again, thank you for inviting me to talk about this. You've already introduced me, so I don't have to do it again. We're from a small center. We have less than 70 pediatric patients. Yeah, it is sort of in my eye. Yeah. So we have less than 70 pediatric patients, and we also have about 100 patients. And actually, one of the people at the table is our adult CF social worker, adult team. He is an adult too, so we always mix up the language. Yeah. Okay, I don't have anything to disclose. And this is our timeline. So, I was hired in 2008. Since then, it's been my responsibility to develop a transition protocol. I didn't do so alone. Again, the team is here. By attending, one of the things I did was attend all of the NACFC talks since 2008 on transition, and I collaborated with many over the years. We've created a protocol that works well. Some days we say it works pretty well, and some days we say it needs some refinement. It's a little clunky at times. So originally, the pediatric team developed a protocol. In 2015, both the peds and adult social workers began collaborating. I worked with about 6 adult social workers in my 15 years. Each has contributed to this product. I've had social work interns who did literature reviews. We surveyed the patients and the families for needs assessment and trying to figure out how to make this work the best for everyone. And eventually both teams developed a joint subcommittee working group. So, sorry, I lost my place. In 2015, we learned that the lack of patient knowledge really inhibited the transition process. Because, of course, without knowledge, their anxiety goes up, and it just really became clear to us that we needed more education to help patients get ready for transition. So most recently in 2022, we began a pilot of the pre and post-transition survey. I'm going to talk more about that, but thank you to Emery. We took your document and we made it work for us. In this business, right, there's nothing wrong with shamelessly borrowing and adapting.
I love it when you borrow those things. So
Yes. It worked really well. We didn't have to recreate the wheel. We just needed to make the wheel smaller.
that's okay.
Okay, so my role as a social worker. How many social workers are in here? Okay, so like you have a million responsibilities, right? I've exaggerated, but really always transition has kind of fallen on my lap. It's like whenever anybody said, well, we need to do something with transition, I should have transition tattooed somewhere on my body, but I'm not a tattoo person, so we'll skip it. Okay, so I chair the subcommittee, which means I pull everybody together and I collect the ideas and I try to assimilate them, and we try to implement them into the evolving protocol. Okay, and ultimately I report back to the joint teams what we've done, and they do get a voting right. So this is the first half of our actual transition protocol. It's too big for one page, you wouldn't be able to read it. I'm just going to highlight some of the things that we've done. So, of course, our goal of the protocol is to make the transition smooth. No pun on smooth operators. I just couldn't help but use the word. And as efficient as possible. We started talking about transition at diagnosis. So the families know, you're not staying in pediatrics forever. You're going to grow up and you're going to go to the adult team. And as they grow up, we layered the education to support their knowledge of cystic fibrosis so that they're prepared to take care of themselves. At 13 years of age, we talk about transition protocol. We give the patient a hard copy of this protocol and explain to them and their parents what's about to happen. At 15, we start independent visits, and at 17, Andres is integrated into their care in the pediatric clinic. So he comes for every one of their visits between 17 and 18. So we plan to transition at 18 years of age and completion of high school. And after you write that, you start laughing, right? Because there's very rarely is it that well defined. We really do try to take special considerations, and oftentimes we have to. There's a few that just go seamlessly, but we have 19-year-olds who are still finishing high school. The adult team is not prepared to work with schools, high schools. So we keep them till they're done with high school. A lot of times if they're 19 years old and still finishing high school, they still have some maturity issues to work with, so it makes sense. So for example, another special consideration is that we have two siblings. One is 19 and one is 17, and they come from far away. And in order to transition these both with a good outcome, we're going to transition them together, even though one is not even 18 years of age yet. We can get the liability things signed off, and we feel that's going to be a better outcome instead of holding one back for a super long time and having him sit on, the fire engine exam table when he's really ready to do adult things. So, as I said, at 17 years of age, the adult team social worker comes to meet with patients during their pediatric clinic visits. These visits are to begin to engage the patient with the adult team, and the social worker discusses details of adulting. I'm not normally in there. Andres is in there meeting with them, and so he can tell you more some other time about what he talks to them about. I'm not trained in adults, I'm trained in peds. Education tools. I said earlier on that we found that education and patient awareness of cystic fibrosis was one of the barriers for transition. So we use these education tools to inform and assess and to help us figure out where the gaps are in learning. There are a lot of education tools out there, and I'm just going to talk about a couple of them. Each discipline educates using their own age-appropriate and discipline-appropriate tools. I'm talking about social work. I got the microphone, so I'm dealing with it that way, because there's a lot. I mean, nutrition does a lot. I think there's a lot in CF Rise. Our respiratory therapist actually ended up writing some of her own education tools. So CF Rise is really easy to access. You just cfrise.org. The Cystic Fibrosis Foundation is doing a great job to update that regularly. The Johns Hopkins Kids Corner is a really great website. It's really kid-friendly, and I can print off coloring pages. I love to give kids coloring pages. I'm the one with all the crayons when I come to clinic, and these are really good ways to have conversations with little kids about big topics. So I highly recommend Johns Hopkins. This is one of my favorites, and I don't think I have to say very much about what this picture says. I like to use this starting at 6 years of age, and it really helps facilitate the discussion about growing up, that the patient is growing up and the parent is going to be in the background. This is a part of a bigger document from CF Rise, and I just cut out the picture part to show you. It has a really nice checklist that goes along with this that you can give to families, and they can look at that. This is another one of my favorites. Again, really good pictures. It's slated for 10 to 15 years of age, but I do start earlier. And again, I will start with crayons. We start with a conversation. I don't put it in front of them and test them. I just try to have a conversation until they're really ready to answer this independently and know this information. And we can go through 3 or 4 visits of this document before they're really owning this information. It's got a really good segue into bronchodilator education. That's one of our biggest challenges. So here's a little bit about our pre and post transition survey. Again, thank you to Emory. We have an N of 4. I told you we're a small center, so I've had 4 patients that have filled out our pre-transition survey. But the transition subcommittee used that information and made a really quick change to support patients concerned for who to call between the last pediatric appointment and the first adult appointment. So ultimately, we as the pediatric team made it much clearer that the pediatric team will care for all med or emergent needs until the patient has actually walked into the adult clinic. And that's up to, I think, 6 months. I can't remember what we decided. 6 months, I'm getting nods. Good thing you guys are here. So it's about communicating clearly so that they understand what's happening. Again, if they don't know, their anxiety is going to go up. Some of our strengths are that now we have a level of collaboration between pediatric and adult team. We haven't had this kind of collaboration the whole time I've been there. So it's 15 years. I can't tell you when we really started to meld, but we do work really, really well together. We have standardized this transition protocol. It is working, and it also gives us room to tweak it when we need to. We have the transition subcommittee, so it's kind of our job. And did I ever tell you who was on the subcommittee? I think I forgot. Okay, so the subcommittee is the 2 social workers from both teams. It's a nurse practitioner from both teams and a pediatric doc that was really, really interested in the transition protocol. So we have a subset of the people on each team and bring these discussions to each other and then bring it back to the larger team. And of course, one of our strengths is education tools. We've really pulled them together. I love CF Rise. They did not pay me to say that, but really utilize it. It's so well written and it's right there for you. Some of our challenges is a high turnover of staff. I told you I've worked with 6 different social workers in 15 years. When one leaves and comes back, they've added to this protocol. It's been helpful. But when social workers leave and when other practitioners leave and come in, it does slow it down a little bit. We've got to get everybody on board, sort of get the machine oiled so they know what we're doing and how we're going to do it. So again, we've had few active transitions. In 2023 was the largest number of potential transitions, and it was 8. And everybody took a breath when we said 8. So we don't get that. We just aren't a big center, so we have to practice really well with the ones that we do. Early on, the transition process was not standardized, and I also have to say that one of the other challenges is that we are a rural center. So some of our families, I was in a talk earlier with our colleague from Idaho, and I thought, yeah, that's one of the barriers, because some of our folks have to drive 5 hours to come to clinic. Yeah, if it was 5 miles, that's not a barrier. Yeah. No, they're coming from all over New Mexico, and some of them live closer to Arizona, and some of them live closer to Texas, but they still come where their home center. And so that can be a barrier with making a transition as smooth as we'd like it. So, as I said, we've come a long way. The most important lesson for me is to listen to all the ideas from the patients, the families, and all of the team members from their experience about how to make this transition smoother. So I thank you for listening to me. This is my last presentation. I am retiring in December. Thank you. Wait. It's been an honor. So thank you. Love you.
My God. That was Brett Favre level.
Oh my goodness. Oh my goodness, Nana, we are so honored. We had no idea. Obviously, we are so honored to have you share. I forgot to add that we're going to do a Q&A at the end. So we've had some questions come in. Keep submitting them through the app, or you can come up to the mic later, but we'll save that for the end for the whole panel. And I love that the transition subcommittee is so multidisciplinary, which is great.
Yeah, I'm going to take my water back.
Oh, I was like, oh, yes, of course.
Thank you.
And I love how you pointed out about refinement and tweaking for tools, because I know sometimes as centers, and you mentioned with like turnover or just 6 different people leaving throughout the years and all these projects. Like I have probably like 20 projects on the back burner, and that was like 6 social workers ago, 12 years ago, like different things you're interested in or that you're getting funding for. So it's always great to say like, we're working with what we have. That's okay. We're learning from other centers. Some are doing things better than us. They're different centers, but we can always refine, take a look at our practice and learn from each other. And I do love that the CF community, professional community and personal, but professional community is so collaborative and so willing to share, which is evidenced by Emory and, sharing their tools and things. So next up we have Diana Greenland, LMSW. She is a social worker at Children's Health Dallas. She received her BSW from Texas Women's University and her Master of Science in Social Work from the University of Texas at Arlington. She is a pediatric CF social worker at Children's Health Dallas and has been in this role since March of 2020, which is a very interesting time to start, I'm sure. We all know what happened then. She follows CF patients and their families in inpatient and outpatient setting for continuity of care. Previous to CF, she's worked in medical social work for over 30 years. Most of her work was as a solid organ transplant social worker. I know you mentioned kidney, and then both adolescent and adult heart and lung transplant patients from 1996 to 2009. So she brings a wealth of knowledge, and we are excited to have her. Welcome, Diana Greenland.
So when I wrote my little biography thing, my daughter, Abby, said, "You didn't mention me." So I'm mentioning her because if she sees this, she's going to be mad at me, and I don't want my spirited child, 16-year-old, to be mad at me. So anyway, all right, so. There you go. Okay, so just use this to. Easier to just use this. Okay. All right, so I have nothing to disclose. And so in our center, we have approximately 273 patients. Of those 273 patients, we have about 40% that are government funded and 60 that are commercial funded. So in 2022, we had a total of 13 patients that were transitioned. 30% of those were Medicaid patients, 10% were children with special health care needs, and 60 were with commercial insurance. This year, we're scheduled to transition 15, and of those, 33% will be Medicaid and 67 will be commercial insurance. We generally start to transition our patients between 19 and 20 years of age. We have transitioned some a little earlier, especially if they're going out to college out of state, they may want to go to another center. So, but generally 19 to 20, sometimes as late as 21. Oops. Sorry.
Okay, it's tricky. We got a tricky mouse pad. Let's see. Oh, sorry, I went back.
The arrows might work too.
Is that the one you wanted or one more? Okay.
Oh,
Yeah, you
yeah.
did.
Okay. Okay, sorry.
Okay.
Sorry, guys.
It's okay. So just hit the right.
Okay. In terms of when our patients are getting ready to transition, we start to think about the insurance coverage that they have. So do they have private insurance or do they have Medicaid? If they have Medicaid, we're looking at, do they have SSI, which is Supplemental Security Income Disability, Medicaid, which generally you keep that to the age of, through the age of 21 if you continue to meet the criteria for disability and income level. If they have traditional Medicaid, then we know that they're going to lose that Medicaid the month that they turn 19. So, and then we also have the children with special health care needs in Texas, which we're really fortunate to have. And that generally ends at 20, with the exception of cystic fibrosis patients. And as long as they have cystic fibrosis and they meet the financial criteria, then they can continue to be on the CSHCM program. Let's see. When we're looking at their commercial insurance, we want to make sure that the parents are going to keep them on that till they're 26. If they are going to keep them on till 26, then we have a whole different conversation with the patient. You know, what are your plans for the future? Some people want to, you know, be a welder, and that's fine, that's great, as long as their focus is going to be on insurance, because we need to make sure that they're going to have good insurance once they become adults that can cover them for whatever comes up. We do have patients that have insurance and then lose it for whatever reason. And so if they apply for Medicaid, then they don't qualify, they have an automatic open enrollment period for the Affordable Care Act. They can apply at that time for the Affordable Care Act, which is good. Okay. Yay, I did it. So in terms of our patients that have children with special health care needs, we have them apply. And again, I mentioned that they can apply beyond the age of 21. When a patient has Medicaid, we're encouraging traditional Medicaid, which again, they're going to lose that at 19 when they turn 19. So we're going to go ahead and have them apply between 16 and 17 years of age so that we don't get caught without any coverage. The SSI Medicaid patients are usually encouraged to apply a little bit later, 17 to 18 years of age. And then we talk to the families about all the information that needs to come with the application. So, as you guys know, government applications can be a little cumbersome. So if they need help with the application, I sit down and help them. If they're able to finish the application on their own, then I encourage them to keep a copy of the application so that they can fill that out next year. And then also bring a copy of the supporting documentation that goes along with the application. I like to submit the application for the patient because then I know that everything is going with that application, in addition to the physician certification form. So I know it's a complete application. One of the things with CSHCN is you have to apply every year. Oops. Left. I was doing left.
It's okay.
I'm a little challenged when it comes to this. I apologize.
It's not just you. It's okay. This is very true. Okay, so let's go right. We're going to slide. We did two.
Yeah.
Good there.
Yeah.
Good there.
Yes.
Barriers.
Yes. Thank you. All right, so some of the barriers that we've encountered in the past is having a parent that no longer wants to insure their child. I think we had one that was, I believe, 18 years old. The parents pretty much disowned him at that time. And so we had to figure out what other options were available to him. This patient in particular was sick, enough that qualified for Medicaid, so that was good, and they were able to qualify on their own income. My coworker, Stacy, she did a really good job in trying to get this patient additional supports. So he was like in a transitional housing program. She did a really good job with him. And then helped him to apply for CSHCN as well. So sometimes patients or parents will lose insurance because of job loss. So at that time, we look at, can they afford COBRA? COBRA's pretty expensive, and not everybody has that luxury of qualifying for COBRA. So then we look at, do they qualify for Medicaid? Do they qualify for SSI? With CSHCN, do they qualify for that? The problem with CSHCN is that there's a long, long wait list. In Texas, they have not opened the program since 2022. And I recently spoke with one of the caseworkers who said that her superiors told them not to expect the program to open up anywhere in the first quarter of 2023. So we have these patients that are on the wait list but can't get services, which is really, really difficult. So again, that's why we try to have them apply early on. And there is kind of a priority list when you're applying for CSHCN. They look at, one, do you have any insurance? If you don't have insurance, then you're closer to the top. The other thing that they look at is how many years you've been on the wait list. So the caseworker that I spoke with earlier, even though we have been referring them to apply for CSHCN 16, 17 years of age, she said go ahead and have them apply as soon as they have the diagnosis of CF. That way they can, even if they have private insurance or Medicaid insurance, they can continue to be on that list if something else happens. And then again, like I said, if you apply for Medicaid and get turned down, that's an automatic open enrollment period for Affordable Care Act. And then at that point, we just talk to the patients about what programs we're in network with, and hopefully we're in network with something. The ones in Dallas is not a problem. It's the ones that live in the little outlining areas that can be a little bit more problematic. So we do have a community hospital, a county hospital, which is great. Unfortunately, they don't have specific CF care there. They have a lot of different specialties, and the patients can be referred there for GI care or anything else, but they don't have a specific CF physician. Okay. And then our adult transplant center doesn't necessarily take all of the Medicaid programs. And there's another hospital that doesn't take Medicaid at all, which can be problematic for our patients. One of the other barriers is a lack of understanding of the importance of insurance coverage, especially when you're talking to a 17, 18-year-old who doesn't really get it, that, you know, they have to have insurance. I can't tell you how many times I've talked with patients and parents telling them, your child is going to lose Medicaid when they turn 19. We're not going to be able to see them any longer. You need to get insurance. You need to complete these applications so we can go ahead and get them on the wait list. And they don't really listen. And then when they're, you know, when the time comes, like I said, the CSHCN has been closed for a year and a half at this point. And so then we're kind of forced to refer them to the county hospital if they live in Dallas County, or we're looking at, again, insurance as another option. Do they afford, are they in college? Is there a college-sponsored program that they can apply for? You know, sometimes I'm sure all of you all have told them in the past, go work at Starbucks. They give you benefits for part-time employment. So we do that quite a bit. One of the other barriers we've run into is just the parents completing the paperwork for the application for Medicaid. It's been a little challenging with the end of the public health emergency. I don't think parents just necessarily think about that because they were automatically approved for so long. And now that that's over with, you know, they're having to remember to complete the application. We have patients that have moved and the families didn't tell TDHS that they moved, and so they don't realize that they lost their Medicaid until the letter finally catches up with them, which can be a problem as well. Thankfully, there's patient assistance programs that can help these patients with at least their medications in the meantime until they can get their insurance back. Okay. Let me see if I can do this right. Hey. Okay. So these are some of the handouts that our Office of Transition came up with, and I really like these. They go over the insurance, so it talks about what's a deductible, what's the benefits, and so we give these patients this information when we're meeting them for transitioning so that they can start to kind of get a better understanding of what we're looking at. The second little handout is really kind of neat because it has a picture of the insurance card and it goes over everything with the patient. So I start telling the patients, you need to start carrying your insurance card, get a copy when you're 17, keep it in your wallet or purse, and then bring it to me, and if you have any questions, we can kind of go over that. So I think that's really good for adults too, because I don't know that a lot of adults know the difference between a deductible and out-of-pocket max and all that fun stuff. So anyway, all right. And then I have to acknowledge the core group of our transition team, and then our cystic fibrosis clinic at Children's Health, and then the Office of Transition that provided us with some of these things. Thank you.
All right. Thank you so much. That was fantastic. So I'm here to introduce our next speaker, who is Christy Gott. So Christy is a pediatric nurse practitioner at the University of Virginia Children's Hospital in Charlottesville, Virginia. She's been caring for CF patients and their families for 20 years in many types of settings, but with a steadfast passion regarding quality initiatives and partnering concepts. In addition to caring for patients, her current work focuses on, quality improvement in the realms of CF transition, which is exactly why we have you here today. So I really need some reading glasses. This is embarrassing. My best days at work, she says, are when she gets to take time to share important events in the lives of many patients and their families, as well as assist with problem solving and overcoming barriers, which is exactly what transition is all about. So currently, she is initiating a transition pilot program in her children's center, and she's going to share her awesome work today and talk about the fabulous way that her team has done that together, and we're excited to hear about it, Christy. So, thank you.
It is true, I get to be here today to talk about my favorite topic, so I'm grateful for that. Thank you. I'm going to walk you through what we've accomplished over the last 2.5 years using QI to guide our way. Let's see. Does this work? I know it's not. Just do this. I don't like it. Okay. I have no disclosures. So in sharing our team's experience today about building our formal transition program, I'll just walk you through a brief overview. It felt like starting a very long hike when we were already busy dealing with some really tough transfers. So we had to get comfortable with stopping along the way, and as always, while on the trail, supporting each other to accomplish the tasks at hand. We discovered with the amazing guidance of our QI coach and CF parent, Rhonda List, that using QI as a roadmap, or in this analogy, a hiking map, it was an extremely helpful way to scope our work and then start scaling it to our own needs, as well as more fully dissect our problems and barriers. I'll go through with you a couple of the methods we used that may be helpful to you as you either start or reevaluate your own transition programs, as well as some of the key tools and resources that moved us toward success. We are very happy with our early results, but also know that we need to keep making change happen to ensure continued success. The big takeaway really is that a transition program is not a one-size-fits-all situation. Every person gets the basic pieces, but also deserves customization or personalization to come away with the best outcome. The story began with patients. It only takes watching one have a suboptimal transfer to make you want to make change happen. The motivation to more closely examine our processes started with seeing patients have needs that we just weren't meeting as well as we wanted to. This, in combination with an amazing DMP student who approached me about a capstone project at just the right time, made for the perfect moment for us to take action and commit to a big build. What the existing research shows us about transition matches up exactly with what our clinical team has experienced. It indeed takes all of childhood to get ready to do this. And we have to figure out the best ways to partner early so that the patients feel empowered and successful when it's time for transfer to the adult team. We first assembled what I think is the most amazing subgroup ever to tackle the work that was needed. This same group is meeting 2.5 years later, and everyone is so dedicated to this project. These people, plus the monthly meetings that we were very steadfast about, are really what has driven the work forward at our center. We've put many tools and trackers in place to monitor our progress and the satisfaction of our patients. Consistent connections are vital during this time period to have a better outcome. We started with an extensive literature and resource review, both inside and outside the CF arena. And each of us had no trouble at all connecting with our own personal why for doing the work. We learned quickly that QI is really messy. And we had started by introducing the concept of transition widely to our patients and families all the way down to the age of 3, but then sort of had to scramble around to refocus ourselves on the patients that were nearing the transfer window. So we scoped out our most pressing issues, defining the problems and mapping the processes during this time frame. And when we were defining the problems, we noticed that some of them were in content, some of them were with tracking, Some of them were with mapping and processes. And when we were defining and dissecting problems, we noticed that they were much more complicated when it was a process that seemed to have a lot of barriers in the way or many stakeholders involved. This slide I'm showing you is one of those. We used this failure modes analysis as an example of the dissection of one of the more difficult problems, which was our meet and greet sessions with our adult team. These are set up during the last quartile of the pediatric year, and it was a process that had pretty significant issues. Not only were we trying to set up these meet and greet sessions with 2 different CF teams, but we were also trying to get them done well. It had been a virtual process during the pandemic, then at times post-pandemic was becoming in person again, and at present state can still be a hybrid process. So we had to dig deep and figure out where we were falling down and try to put more structures in place for these very, very important events. Use of this tool has been especially helpful for understanding all of the relational junctures that were present in the multiple processes, both on the ped side and the adult side. There were many changes and improvements that needed to be put into place to make this work for both teams as well as the patient. Some examples of interventions that we put in place were obtaining a special PVP for this group of patients so that both teams would be aware of last-minute changes in the patient's schedule or whether they canceled. And also more structure was put around examining the schedule of the adult providers a little bit more closely. And as always, hearing the patient voice is important. So we wanted to put an evaluative process at the end of these sessions to hear what patients were thinking about them. Once some of the main problems were dissected and plans for new processes were put into place, we were able to start looking at the larger picture and focus on our theory for improvement. We had so many good ideas and process pieces, but we really lacked a systematic way for applying and tracking them. So let's take a closer look with this model at some of the methods we used to get started and now in a sustained phase. We clearly stated our global aim, as well as several SMART aims about the program. And we also had to get comfortable with the fact that QI work is not always linear. We often had to work back to solve a problem and then go forward, especially about putting the cornerstones of the program in place. Our aims led us to some very specific interventions that would organize, standardize, and track a series of processes that were housed under our new program. None of these processes had any prior measures, and there were no existing tools. So using this key driver diagram, we were able to organize what we learned from the literature and best practices of the CF community to create the theory for our own work. The key drivers or core elements were the conditions that we felt needed to exist to reach our goals and interventions, and they were designed and tested through multiple PDSA cycles. The key drivers are noted in the midsection of the slide. Change ideas or interventions are located on the far right. Gray boxes have been adopted and are in a sustained phase. Several others, such as the EPIC flow sheet, the interdisciplinary presentations, and timely ID for the time frame of the final year, will also be shifting to gray in the near future. Items that remain on our to-do list are in white. Set monthly meetings to review changes and discuss adopting or adapting actions greatly benefited the movement forward. In addition to monthly meetings, each of us was also working behind the scenes to formalize the tools, track the processes, and hold each other accountable for honoring our intentions on a weekly basis. Let's take a closer look at how we standardize the workflow. At the top, you can see the categories for our monthly spreadsheet monitoring. We anticipate the patient's transfer year, monitor their last 4 co-produced visits with us, their readiness assessments, their dates for team presentations, meet and greet sessions, and future visits. Our routine joint meetings with the adult team are on a quarterly basis. We have a shared EPIC patient list so the adult team can see the patients that are queuing for transfer. And we also have a back-end care team member checklist to guide the patient's final year with us, or those 4 final co-produced visits, which you can see in the middle. These tools and processes, plus weekly monitoring of the EPIC flow sheet use during our clinic huddle time, have all aided us in being consistent, as well as involving the entire team with the patient-facing elements of the program. We also discuss transition needs and identify who will cover those needs during our weekly clinic huddle, and this is marked on our clinic tracker for the day. Our EPIC flow sheet use has really allowed transition data to be visible by all, since all in the Children's Center, since it's now in their medical record. It's improved partnering, goal setting, and progress reporting on each individual, whether the visits are in person or virtual. Use of this has invited many engaging conversations with patients and families regarding attainment of transition milestones, as well as goal setting for the future. And it serves as an excellent communication tool with the adult CF team about milestones or tasks that still need attention at the time of transfer. Transparency of this process throughout the medical center is essential for good communication, optimizing care, and managing up this important work in our organization. 2 years later, we are finally getting to some of the larger scope work. One example is this decision tree regarding the timing of transfer, which is an area where we would like to have some more consistency. Management of this process and having a tool to support it relates right back to our KDD, specifically the timely ID of the start of the final pediatric year. Reaching consensus on a decision tree like this helps us to ensure that our processes going forward are equitable and consistent with our patients. Now we are able to be more focused and planned, targeting specific areas for continued evolution or reevaluation. I'm happy to share that our results are positive, and we are seeing success. We realize we still have work to do in certain areas, but overall, the processes and tools that we have put into place are greatly benefiting our patients and setting them up for success. Success means a better health outcome. I'd like to call out a couple specific PDSA cycles, 4 of many, that enhance this improved outcome. Implementation of 2 readiness assessments in the final pediatric year, use of our integrated EMR flow sheet, the final year patient care checklist for subgroup members, and lastly, our weekly clinic tracker. Together, these 4 cycles have helped us to reach our goal. This depiction of our results holds us accountable on all the pieces of the program that we are measuring and the success of each. Some areas are very solid. Other areas with more moving parts have been harder for us to attain consistently. Current areas for reassessment and adaptation are consistent documentation, more targeted responsibility during clinic, and revision of some of our goals. And just to call out for the low percentiles on the co-produced final year visits and readiness assessments. Some members of our cohort were just too early in our tool and process development to have benefited from these pieces of the program. We can already see with the additional patients in the queue that these measures are being met. And what about our SMART aims? Well, our mean satisfaction score on our meet and greet survey was 23 out of 25, or 92%. Our patient readiness improved to 97%. And all young adults in the program had robust use of the EMR flow sheet. None met the 95% of initially designated milestones. But I'll say that we set our goals too high. We have many next steps. Tried to make it succinct. We do have a post-transition survey that is developed, needs some small revisions, and a plan for implementation. We will partner with our adult CF care team to get that done. We continue to build our own transition program, but also are reaching out to help other specialty peds clinics in our children's center to share the fundamentals of how they might also build their program. We will continue sustaining our processes and adopting and monitoring for reliability of our measures. It's no coincidence that this starts and ends with patients, those that have transferred and those are getting ready to launch. And if you leave here with anything about this project or QI, resource development, know this. This work is so rewarding and beneficial to our patients, and they're so grateful and healthier when this process runs smoothly. We will keep using the patient voice to guide our work through all the different phases of life transition, which starts right from the very beginning and is an essential piece to doing this the best way. It's important that we follow the same process for each patient every time to ensure equity in our transition processes and co-produced care at each phase. I'm thinking of all of our patients that are preparing to take the next steps in their transition process. You see some of them here. And I'm feeling great comfort that their experience doing this hard work is going to be a good one. And the last thing I'll say about this process is that the pride and empowerment our patients reveal to us when we partner with them fully to enhance independence is one of the best gifts you'll ever receive. Thank you.
Gosh, she's got me all teary now. One thing I want to point out too, Christy has such a fantastic team, a lot of which are here right now. But one extra layer that I just love about your team is that one of your QI specialists is also the mother of an adult with CF. And it adds an extra layer of just partnering and knowledge. And it's something that I just love and admire. So, all right. See if this mouse is going to cooperate. So up next is Megan House, who's from my home center of Children's Healthcare of Atlanta and Emory. Megan has been a nurse with Children's Healthcare of Atlanta for 7 years. She was first inpatient on our CF floor, and we are so thankful that 3 years ago she came to our outpatient CF clinic because our clinic staff and our families absolutely love and adore her. She says she's thoroughly loved the relationships that she's developed with the families and is thankful to be sharing one small part of the piece of transition to adult care. So she's going to talk about a special project.
Thank you, Brandy. All right. It is all about trust. No.
Oh, trackpad right. It's okay. I know, it's so tricky. Yeah, it's tricky. Yeah,
Okay.
very tricky.
We'll get there. We'll get there. We will. I have the following disclosure. Our work was a part of the Improving Life with CF grant. Just to tell you a little bit about our center, we're a pretty large, I think we're at like 403 patients right now, pediatric-wise, in the Southeast United States. We also have an adult care team that we closely work with. We also have the only lung transplant center in our state, and it is within the university system that our adult programs with. And we also have the great pleasure of having our adult CF program director as part of the lung transplant team as well. Down there. Our formal transition program starts at about 12 years old. They complete 15 modules over the course of 6 to 7 years. Most of the time, these modules are completed with our same transition coordinator, some with the social worker, and some with our dietitians. Brandy is such a blessing to us. She's employed by both Emory and CHOA, so we get to kind of bridge any gaps that come through with transitioning to adult care. In 2023, as part of a larger primary palliative care initiative, Improving Life with CF, we noticed that our patients were being approached at the check-in desk by non-CF staff members. At their 18th birthday or the visit thereafter, they were given a chance to complete an advanced directive. But what it really was a check yes, check no. Do you want information about this? Do you not? And unfortunately, nobody completed one, and they were really unsure what they were actually being given. Preparing for adulthood is impeccably important for young adults, especially with complex medical conditions like CF. And one of those needs is to document their wishes and advanced medical directives. Our chart review revealed that we had about 28 patients that were 18 and over, and none of them had completed an advanced directive. And in addition, none in the last 5 years in our pediatric program had been completed. Like all new processes, we had several challenges to overcome. We made a key driver diagram with our QI specialist, and our barriers kind of fell into 3 categories. The first was getting our staff educated. We had one QI meeting, and it was pretty efficient. All of our providers kind of bought into implementing a new transition module and understanding the importance of having the conversations regarding advanced directives. We also were able to gather all the information from our hospital system. They had all the teaching sheets and everything that we needed. It was just not being utilized. We also were able to prioritize time for this to be completed in our pre-clinic huddles to ensure that there was adequate time to talk through any questions. Another barrier that we have faced that's kind of ongoing is the lack of our electronic medical record flagging this in their chart. We're able to upload it, but unfortunately it does not flag that it's existing there. And we're building a new hospital, so as we all know, with technology changes like that, this kind of gets put on the back burner for IT focus to finish that. So we'll see how long that takes. Part of overcoming these barriers began with just a basic knowledge assessment. We put a work group together with 2 young adults with CF to brainstorm ideas and get their feedback. Speaking with them helped to reinforce the idea that it's best to get a baseline of knowledge before having the conversation. So the Advanced Directive Knowledge Assessment worksheet was created. It allowed them to rate their knowledge on a 0 to 10 scale, as well as answer in free text what they knew about it. People were asked, what is an advanced directive, and provided us with some really fantastic answers. One thing I was very much encouraged by was the fact that most of the time it related back to just general adulthood, like car accidents. It was not disease-specific focused. People were really honest about their answers, and we appreciated that. This was one of our patient advisors. He was the first to complete the advanced directive, and he asked to take a picture. He had recently gone through this with a family member that did not have one on file, and even at a young age, he understood the importance of getting this completed and was very thankful to have had this done. So after about 4 months, 22 of the 28 people were approached in clinic to complete the advanced directive module. They all agreed to do it and rated their knowledge very low at 0.8 out of a 0 to 10 scale. Among them, the average age was 18.9 years old. Most had good lung health with a median FEV1 at 89%. And this showed that while on average participation, the participants were pretty healthy, we did have a few quite low FEV1s for pediatric patients. Interestingly, we did have more females complete than males at 82% compared to 76%. And it was very encouraging. Completion rate was highest among people with CF and minority groups. All 4 out of 4 individuals who identified as Black or Hispanic completed advanced directive after the intervention. It was also interesting to note that we had 4 patients with CF adult siblings, and 3 of the 4 of them chose their sibling as their healthcare proxy. One young adult noted, this decision might be very hard for my mom, but I know my brother gets it. So we were able this year to complete our first transition clinic where we could move our patients through to the adult care team with an advanced directive on file for them to take with them and carry with them into the adulthood lives that they were about to live. We really feel like the trust that they have had with the team, with the providers kind of initiating that conversation, and then they've gotten to know Brandy over the last several years, have really encouraged them to complete this. We also had a lovely ripple effect where several CF care team members, myself included, researchers, non-CF adult siblings, and parents wanted to complete one as well. So just a very positive outcome. So thank you.
Great job, Megan. That was her first NACFC talk, so
You knocked it out of the park.
all right. And next, I'm so excited to present literally one of my favorite people on earth. That's a short list of people. Dr. Randy Hunt. He really doesn't like it when we read all of his accolades, but you don't have to. See, this is how it goes. So what I can tell you is that some of the tools that we've designed that other centers are using, Dr. Hunt has helped me even back when I was a doctoral student design in my DMP projects. He is so integral to creating my position, to coming over and having transition clinics and not getting reimbursed, and moving everything that happens at our center with transition. So he is our adult program director. He's also part of the lung transplant team at Emory, but more than that, he's just an awesome human being. So he's going to talk to you a little bit about what he's experienced from the adult perspective in the last decade or so, and hopefully give us some insight into that.
All right. Well, thank you, and thank you both for letting me share some musings today. So thank y'all. I don't have any disclosures, but I think I have some disclaimers. So what I'm going to talk a little bit about today, I've been fortunate. So I did medicine and pediatrics, and that's when I really got introduced and interested in transition care. And that has carried over into my more adult life, I guess. I get to work with Brandy, and we've had a very, I think, biased but strong center of transition for many years now. And so we've transitioned well over 100 individuals just in the time that we've been together. So some of these are just thoughts that I've had. As best as I could, I've tried to put them in with some like evidence-based guidelines, but some of them are just musings that I've had. And so they're always open to comment if you feel differently. So here, without further ado, are 10 lessons that I've learned from 10 years of transitioning. And this has come up several times already today, although maybe not so bluntly, but age is just a number when we're talking about transfer and transition. And I know we normally think about that in terms of like, oh, you can be youthful at any age. And that's true, but it also means that you can be immature at any age too, right? So I think, and vice versa, you can be mature. I'm sure we can all think of 16-year-olds that we trust and are like totally crushing life. And I can think of 40-year-olds who are still struggling to adult, right? And so I think you have to be very thoughtful. And everyone on the panel so far has sort of alluded to this, that transition and transfer timing is more about readiness than an age. But for a long time, age oftentimes does prompt the transition discussion and transfer, because I guess it's just sort of an easy, external marker that you can look at. The foundation actually even has recommendations. They recommend that you transfer by at least the age of 21, but that's sort of it. It's nebulous otherwise. And if you look at across the world at places that do have a lot of transition, not just out of CF, but any young adults that are living with chronic illnesses, it varies very widely. So anywhere from 16 to 24, and I'm sure there's still some places that are carrying around adults. And part of this, as you know, is because maturity doesn't always correlate very well with age. So some of the state actually comes out of law, which makes sense, the juvenile system. So this first study up here in the upper left-hand corner actually looked at more than 5,000 young adults from the ages of, I think it was 16 to 30. And essentially what it found is their cognitive ability is pretty much adult levels by around the age of 16, but their psychosocial abilities that in terms of like being equivalent of adulthood are lag way behind. And usually it's well after the age of 18. And then the second really retrospective review study kind of mentioned that there is this idea of the mature minor doctrine, so that minors actually can be more adult-like. And what they find in the research is that if you take generally people who are over 15 and you take out any emotional distress, peer pressure, external environment stressors, then they can make decisions similar to adults. And like we all know, that's every adolescent that we know, right? Like none of them have those problems. No, I mean, every adolescent has peer pressure and stress and emotional things. And so they're always weighing that. So this was actually a retrospective study that I just want to share briefly that was where two pediatric programs that had slightly different cultures in transitioned into a similar adult or a adult program. And what they found in the retrospective evaluation is that the formal program, which tended to transition later around the age of 21 or 22, compared to the semi-formal transition program that transitioned just culturally earlier at around 17 or 18, there was really no difference when the patients looked back as to how they felt about transition readiness or satisfaction. It just didn't matter to them. In fact, 50% of them were happy, and the other 50%, it was kind of divided whether they would have liked to have come earlier or later. And there's no consensus in the data that, when transition timing should be. So when do we transition? I don't know. And I'm hoping, like everyone has said up here, I think it really depends. You have to be very individualistic about it. And I was sort of reviewing some of the literature as I was preparing for this talk, and I found in one of the older papers from like 1998 that said essentially like age is in a good transition paradigm, and we should really look at objective measures of transition readiness. And that was 25 years ago. And you know, we could still say the same thing today. So I'm hoping someone out there in the audience will come up with like really good objective measures of transition readiness, because I think we need them. All right, so number 2, so meet them on their own turf. This is maybe relevant more for my medicine colleagues, but it's true for peds too. So I think it's really important to go meet the transitioning or transferring family at their home center, because it's really scary. So, or it can be at least. So this is my reality at least. So this is the adult team where I am at. This guy here at top, like he's the love child of Orville Redenbacher and Bill Nye the Science Guy, right? Like this guy isn't threatening to anybody. And the team below them is just the happiest, most inviting team that you can imagine. But the perception sometimes is a very different one, that they're all monsters and they're scary and we're going to yell at them for not doing their Pulmozyme that day. But that's not the case. And so everyone knows that the literature has a preponderance of data suggesting that individuals who are transferring have a lot of anxiety around it, both meeting the adult team as well as just the idea of going over to a new center, like infection control and who am I going to be around? And so meeting them in person offers the ability to for them to ask those questions directly and for you to give them answers and to see that we're not actually monsters. So it also allows your two teams, your pediatric and your adult teams, to have direct communication, both verbally and written. And I'm fortunate my pediatric colleagues give it this really nice, like, patient summary data set that's only a couple pages, but it hits the highlights and it's really helpful. And then we get to have this verbal communication, because sometimes there's nuances that you don't necessarily put in the paper that can be helpful. And so that's really, really important. So a couple of things. Again, I'm probably telling you things you already know and believe in, but a few like keys are like, if you're a pediatric team and you're hosting, try to remove the barriers to them coming over if you can. Even silly things like we're not on the same site. So like having the pediatric team cover the parking vouchers is actually a really big deal. Cause like, I don't know, I mean, it's just another barrier to go over and have to pay $10, for something like that. And so it's helpful, like if you have lunch or, to set up a common room so that you can have these communications, that's really great. And if you're on the medicine side, you may have to fight for this. So like when I went to my admin, I was like, hey, we're going to go over and meet all these great kids or young adults, and they're going to come over here. They were like, so you're going to cancel clinic and you're not going to bill for it and you're going to take the whole team away off campus? They're like, no, you can't do that. And then you're like, yes, we will. Because you maybe have to fight a little bit for it, but you're going to tell them that it is associated with better satisfaction, reduced anxiety, and you're more likely to get those young adults to come to your clinic and start the process of building this relationship with them that your pediatric colleagues have had 20 years to build with them. So your administrators are going to let you do this, but you may have to fight them. All right. Sometimes and oftentimes, transition's actually harder for the parents than caregivers, right? I think probably our pediatric colleagues get that. Sometimes my medicine colleagues, and me included, have to kind of remind ourselves about that. So this is almost hot off the press. In fact, it's not even on the press. It's just a bunch of electrons floating around on the internet right now. But this is data out of journal CF that was a really nice qualitative study looking at young adults and their family members, their caregivers, about their experiences with transition. And it was about 18 young adults and a similar number, about 14 parents. And several themes came out, but the two that I want to highlight are parents very much felt like they were co-patients and they were very nervous about the transition too. And you can understand why. There's actually some data that parental anxiety may actually supersede of the patient because, they're 18, nothing's going to bother them. They're cool. But the parents, a lot else is going on. Not only is their loved one, their child, maybe transitioning from a pediatric to adult program, but maybe they're going to school, maybe they're moving out of the house, maybe they're starting to date more. I don't know. I mean, there's so many things that are happening, and now they're getting this like external reminder too because they're transitioning. So it can be a really heightened time. So our pediatric colleagues tend to, treat their clinic visits for family-centered care as they should, whereas medicine tends to be more individualized centered care. And this can be really disruptive to the family dynamic if you don't sort of partner with them and share that. And there's probably like a happy medium ground there too. So just things to think about as you're transitioning and transferring. Okay, so create early successes for your patients, particularly, so this is really sort of pre-transplant. So there's good data that if you feel empowered in your independence, it is associated with increased quality of life. However, there's also good data that if you are trying to force this on an unwilling or unprepared person and push them through it, it will lead to them feeling overwhelmed, inadequate, and maybe withdraw them from their self-care and their program. So what we try to do is help them with experiential learning, essentially, right? So we do a lot of encouraging, we do a lot of cheerleading, and we do a lot of helping them through some of the sort of skill-based processes. We don't do it for them, but we also just try to help them, and we make it a little easier. So for example, one of the things that can be quite distressing is calling the call center. It's horrible. I've done it myself, and it's really hard to get through the adult call center sometimes. And so we teach and coach our patients to do this on their pediatric side as they're getting ready. But we also, unbeknownst to them, have somebody ready already on the other side expecting their call so they don't get the phone tree. So yeah, is that a little bit of cheat? Yeah, it is. But it builds confidence, right? So you're teaching them, it's like having the hoop a little lower when you're learning to dunk. Like, yeah, I'm awesome at this. And then, as opposed if it's already 10 feet high, then they just have a lot of unsuccess. So anyway, I think that's really important. So if you can build those things into your program, these little successes, it just sort of helps them encourage, like, yeah, I can do this. Particularly for, some people are going to be overconfident, and that's a different story. But for the ones that are a little nervous about it, I think this is helpful. Okay, but going into this line, sort of taking this too far on the other end, PEDS colleagues, don't be their crutch. I know you want to be their hero, and because you've taken care of them for so long, but sometimes well-intended support can really prolong dependence. And I'll give you a couple of examples about this. So in one of our studies that we performed, one of the things that we did is that going back to scheduling, we actually would schedule appointments for transfer patients for the adult clinic, like on the day. And when we would do that for them, and we're so proud, like we're patting ourselves on the back, like we're so great, here's your appointment, you're gonna love it. And what we found out afterwards when we actually surveyed them, they had a much more difficult time. They were way more concerned about how do I get in touch with the adult clinic? How do I make my own appointment? They didn't know it because we took that experiential learning away from them by doing it for them. So, for those of you who maybe follow Love and Logic, you can put your Love and Logic hat on so if outside of like a detrimental event that's going to be like, catastrophic for the patient, help them get through it. Like, for example, getting in the phone tree or getting into appointment, or let's say they ran out of their Trikafta and they don't, like, how do I get this all of a sudden from the adult clinic? Help them, but don't do it for them, because sometimes it's easier to do it for them, but it doesn't help them learn. So yeah, that was our experience. But don't worry, PEDS, I'm not singling you out. Medicine people, I've got something for you too. So when they come over, spend most of your time just getting to know them as a person. You gotta understand, I'm sure most of you do, I don't mean to sound preachy. You have to understand if I'm saying this, it's because I've done these things before, and I'm talking to old Randy. Like, when they come up, they've spent 20 years sometimes with a team that knows and loves them, and they're coming over to you who they don't know, and it's a lot like dating. You got to get to know each other first. So it took a lot of time. So really channel your pep, to throw out a plug for that, your partnership. And think about holistic patient-focused approach, not just a disease-focused approach, particularly on that first visit. So I spent a lot of time, more than half my visit, doing a couple things. One, shared agenda setting with them. I want to know what they want to talk about too first. And then I want to know about them. What are their goals? What do they like doing? What are their hobbies? Are they, going to go to school? What do they want to get out of that? I don't start talking about CF or their history of CF until near the end, unless if that's what they want to talk about. And the other thing is, because of our PEDS colleagues giving us this great summary, I know a lot of that stuff already. I don't need that. What I don't know is what they want to do with their lives, or what their passions are, what they're scared about. So spend time talking to them about that. All right. I hope this is antiquated. Perhaps it is. You can tell me it is, but transition's not a punishment. So I mentioned that I did med peds, and maybe this is older now, but I used to do adolescent clinic where we would take care of individuals with diabetes. And don't look up where I went to school, where I went to residency, but like it was very clear that there were some people who when they were 17, if they did not like them or had a hard time with them or thought they were non-compliant, they would get shipped to the adult clinic. And it was very very clearly obvious. Whereas other ones, if they were fun and they were doing great, they're like, oh, they're so great. We'll just keep them through until they're like 23 or something. We don't have to. The problem is like, that is not consistent care, and that gets around. Our patients, they all talk, they're all on social media, and then it's going to get out that if you're, the one that gets transitioned at 16, that you either weren't liked or something was wrong with you. So again, maybe this is antiquated, maybe this doesn't happen anymore, but also don't use transfer as a threatening punishment. I have honestly heard someone say, look, if you don't start doing your Pulmozyme, you might as well go to the adult program. And that sets up really bad precedents for a couple of reasons. One, it sets up transition as like a bad thing. And two, it makes it sound like the adult people are, i.e. monsters, right? And we're not. We just established that I am Bill Nye's offspring. The other thing is, until very recently, you have to remember that moving to adult-centered care was in some ways a step closer to death. So when I started practicing medicine, the median survival was only 28. So if you were transitioning to adulthood when you were 23, 24, that was kind of a marker for you. And, highly effective modulator therapies help that a lot. For a lot of people, that's not the way anymore, obviously, but we still have some who it may be, and it wasn't long ago that it was. So you just have to think about it. So we really need to make sure that transition is celebrated. Like, this is winning the game of life, right? Like, you got it, you made it, and you're going to even do better. And I tell everyone, I know how great it's been with your pediatric colleagues. You've gotten 20 years to know them. You're going to get to know me for longer, right? Because you are. All right, so along those lines. All right, so this should have a big asterisk by it probably. So some young adults really thrive in adult clinic, and you may be surprised. So this is a patient that we just recently, here's our great transition worksheet that we got, so they had, very non-inherent airway clearance, rarely do Pulmozyme. They really struggle with anxiety and depression. They have restrictive food intake. They have a very difficult relationship with their family. That's part of their struggles. They've actually been 1013 before. And then they came over to, so you're hearing this on paper and you're like, oh, this is going to be rough. You're just prepared. You're like, make sure that they're last on clinic day and, that you have plenty of time with them. But 2 years later, they're doing daily airway clearance. They're eating 3 times a day. They've gained weight. They're really happy with where they're at. They have improved anxiety. They've got a new job. They're seeing a therapist consistently. Their parents have not as involved in their life, which in this case is probably a better thing. And did we do all that on the adult program? Yes, we did. No, of course we didn't. Of course we didn't. Like, there were a lot of things that happened. That wasn't just, the adult program. But what I really want you to take away isn't that, like, oh, everyone who does bad in peds is going to automatically do good in medicine. But there are a subgroup of people out there that will rise to the independence that you give them. And so really the last message is what my real take-home point is, not like some people thrive, but like, don't ignore the past, because that past is their reality, but don't make it necessarily the future. Don't hold preconceived notions, because it's a new leaf when they're coming over to the adult clinic. So let them have that blank slate. All right, 2 more and then I'll stop. I know we're running low on time. So avoid transferring during times of acute illness. Again, maybe this kind of goes without saying, but it can happen. So transition, it really should take place at a time of stability. Transitioning usually occurs at a time when there's already increased risk to health, right? So young adolescents to the 20s. Remember, it wasn't that long ago, even though our median survival in our community was 40, the peak onset of death was still in the 20s at that time. Now, that's maybe changing a little bit with highly effective modulator therapy, but it's a tough time. So be flexible with the timing. There are a couple of times when expedited transfer, or I call these crash-in transfers, are just going to occur. So someone who gets pregnant, they're coming over to the adult clinic. If they're incarcerated, we're going to take them over in the adult clinic, or sometimes transplant evaluation. These are not common, but they do happen occasionally. And so that takes me to my last point, is like, it's really important to have a transition coordinator, I think. This doesn't have to be a dedicated, like, your only hat is a transition coordinator, but you all do CF. You're all already wearing like 4 hats each. So it's, either it can be a dedicated worker that does transition coordinator, or it's something that a point person takes on. So there's actually a lot of data in this, just even outside of CF, but having a singular point of contact, it's oftentimes called a transition key worker, is really important. Now, in a lot of the other literature, it tends to be nursing staff, but it doesn't have to be. Social worker, dietitian, RT, a physician, clinician, NP, doesn't matter. It just takes somebody who's passionate about doing it and is willing to organize it all. So it's really great. I think it's important for them to be there for both pre and post transfer activities. So maybe they're getting individuals ready during the transition process, and they're a point of contact after the transition process. And I think that's really important for these crash transitions, the ones that don't get to go through the whole transition process, right? So they can serve in a really important role. And again, just sort of like this person guiding here, you're not necessarily telling them what to do, but you're helping guide them through the process. So let's try to support that. Again, even if it's not a person that you say your only job is transition, have a person, a point person. You can still have a committee that works on it, but a point person that your patients can look to and like, this is the person that is going to help me through this process. All right, with that, I will finish. Those are my 10 lessons. I'd love to hear comments about whether you think some of them are bogus or what your thoughts are. So thanks, guys.
All right, I think we've got just a couple minutes just for a couple of questions. We kind of packed this in just to get so much information out to you guys, so it's going to kind of limit the questions. One question was, were there any patients or caregivers upset with the theme of advanced directive was brought up? Did anyone decline to participate?
No, all 22 people that were approached were very happy to complete. Some were not prepared to maybe make all the decisions on their care, but they were all very happy to become a care proxy once they understood the importance of it.
Yeah, we actually ran this by our family advisory council too first, just to get their feedback, and they were like, "Oh my gosh, I'm thrilled, do it." So it has actually, how many people have said, especially our family, our minority families, our families of color, that no one has ever asked them these things, and they have felt the burden of making those decisions and felt really empowered afterwards. So I think I was really actually worried about how it would bounce off of our young adults, and I have only seen the opposite. Yeah, go for that one.
Sorry, you guys asked great questions. Sorry, we can't get to all of them. Nana, you said patients start doing independent visits at 15. How do you handle and encourage parents who are hesitant to letting their kids do these independent visits and worry they'll miss information and changes? This comes up a lot.
We just kick them out of the room. No, actually, we actually do some education, even with reminder calls. We remind them that this will be, 15 isn't completely independent, it's semi-independent, but we're really practicing. So we're leaving the caregivers in the room with the patient for some of the visit and asking them to leave for some of it and then bring them back in for wrap up. Some go easier than others.
I'm going to summarize this question. It's a great question from about, we frequently hear from adult teams, they're not, don't know how to handle these issues coming from transitioning patients. They're frustrated with peds teams for sending quote unquote messy patients. Whose responsibility is it to understand, become experts? Is there additional training for this adult group? Maybe Randy could answer, or anyone, in terms of inheriting these quote unquote messy adults. I hear that a lot too. Yeah.
Press this button first. Oh, sorry. There you go.
Yeah, I don't like, so this is, I think, where it's really helpful to have direct communication with the teams, right? So if you're not already doing that, having like in-person discussions about these handoffs or transfers is really important. And yeah, so people are kind of messy. So am I. Just, I don't know. Sorry, I'm probably not going to be very fair to your adult team here, because I'm sort of like, get over it. Like, that's, you know, we're here to take care of people, and everyone, you got to meet them with where they're at. And like, don't think of it as messy. Think of it as a new opportunity to partner with someone and help them in life. So I'm sorry, I'm preaching. Let me get rid of that. But
you also say a lot of times when we're like, we're sorry that this person is dealing with these 5 things, and you're like, we have that all the time in adult care. Like, no big deal.
So that's probably unfair of me to your adult team members. But I think trying to communicate more, and then they just recognizing that they're probably stressed. Oftentimes adult teams do not have the same support as our pediatric colleagues. So anything that you can do, again, from pediatrics to try to offload that, whether it's making sure that they have a really good worksheet or making sure that they understand what the insurance complications are going to be in the next coming so that they can sort of prepare for it ahead of time, I think would be really helpful. That's probably more reasonable advice than what I just said about them getting over it. Sorry about that.
Okay. I think that's about all we have time for. But thank you guys for coming today, and thanks to our wonderful speakers. You guys did
Yeah,
something
thank you
great.
so much. Be sure to go to the plenary or stream it. It's going to be great.